I'm delighted to be able to share with you some of my perspectives on what I think are the major pharmacology gaps in aging with HIV. These are my disclosures. I'm an employee of ViiV Healthcare and I own shares in GlaxoSmithKline. Like other chronic viral infections, HIV manipulates multiple key cellular processes to ensure its survival. And many of these are also coincidentally the same processes that determine aging. As an example, envelope has pleiotropic effects on many different types of cells, such as endothelial cells, epithelial cells, cytokine and chemokine regulation, and various intracellular signaling processes such as autophagy and various aspects of cell program death. So over time, these result in local and systemic pathology. And as you can see on the right-hand side, a whole list of multiple comorbidities that we typically see in the setting of older people living with HIV. Exactly how HIV manipulates this and how the age-related pathology fuel each other is clearly a very complex process, but it is evident in the spectrum of diseases that we see in managing older people living with HIV. This has particular relevance to the drug selection and drug discovery process, both in terms of novel targets, but also ensuring that drug development considers age-associated diseases in terms of organ function, drug interactions, and age-appropriate clinical endpoints. HIV is associated with this broad spectrum of cellular pathology. And over time, these multiple different cellular aberrations accumulate either local pathology or systemic pathology. And we see this accumulation of different comorbidities as listed in the middle. I think what's really particularly interesting is that many of these, of course, are also associated with aging. And what we're seeing in HIV, as evidence from multiple cohorts like aging HIV, age HIV, and POPI, is that these are clustered. And this invites speculation that potentially there are common pathogenic pathways and therefore maybe also common interventional opportunities, either specifically against HIV or against some of these age-related or HIV-associated comorbidities. So at the cellular level, HIV interacts with a host of proteins, and particularly the HIV envelope, TAT, and NEF, and several other proteins are implicated in this. These interactions are still being explored, but many of the cellular processes that HIV manipulates, as I mentioned already, are also some of the processes that are really important in determining age. And just as an example, you can see in the middle that just the interaction of CD4 or the chemokine co-receptors CCR5 or CX4 can result in intracellular signaling that determines multiple different cellular processes such as transcription, cell migration and adhesion, cellular survival even, and even programmed cell death. And on the right, you can see the striking difference between the stimulation of envelope, depending on whether it is a CCR5 tropic or CXCR4 tropic envelope. And you can see from the sheet map that the intracellular activation of protein transcription is vastly different between these two, just highlighting once again the complexity of how HIV manipulates various cellular processes. So the industry response is manifold. First of all, and very obviously, our interest in the basic science for drug discovery and target selection, and exploiting the various molecular manipulations of HIV. This means that we are obviously really interested in a lot of these different pathways, because they may offer us a variety of different targets, not potentially just for HIV, but also for other related diseases. Of course, our global network of clinical sites means that we have an extensive reach, and this reach should ensure that at least we are able to include the participation of a vast spectrum of different people living with HIV, so that we can ensure that we have a good representation of different populations, including the elderly and pediatrics. But the inclusion of elderly is lacking for several reasons. One is because some of the sites that we typically engage in don't necessarily have this population, but also because people living with HIV as they age have often been exposed to several different regimens and therefore heavily treatment experienced, and they don't necessarily benefit from some of the newer, simpler regimens that are on offer today, such as the single tablet regimens, and also some of the newer strategies, such as the reduction from triple therapy to dual therapy. However, there are multiple novel mechanisms of action and even novel routes of administration which might well benefit this population. But we really have to consider their specific needs, such as the decline in organ function, different ways of metabolizing drug, and understanding and preparing for potential drug interactions and different toxicities in this age group. Cohorts and observational studies are incredibly important because they often address some of the shortcomings of the clinical development program, and we can specifically target populations like the elderly. And so there are several cohorts that we do support, such as Age HIV in the Netherlands and POPPY in the UK, and several others around the world. But on their own, they are still somewhat lacking, and there is a renewed interest in the regulatory agencies to ensure that observational studies specifically address some of the shortcomings, and particularly around the aspect of aging. Implementation science is a fairly novel avenue for the pharmaceutical industry, but the utilization of the implementation science methodology ensures that we can revisit how the various clinical trials that we do address the access to care, the optimal healthcare, and implementation of an improved process, so that the capabilities that we have should benefit this population. Educational programs, I think, are also somewhat lacking. We've obviously been doing these for many years, but I think given that we are now needing multiple other disciplines to assist with the care of people living with HIV as they develop all of these comorbidities, we really have to extend our reach in our educational efforts to all these other disciplines, such as oncologists and cardiologists, neurologists, endocrinologists, and geriatricians. And the community engagement is also clearly something that we have done for many years, and it is the community engagement that has ensured access to care across the globe in a way that is unique to HIV. But the insights that we can get from the community are still somewhat lacking. So there is a program that has been run now for several years called Ad Hoc, Aging with Dignity, Health, Optimism and Community. And this is an online program including over 1,000 people now over the age of 50 across multiple sites in the US, and exploring several aspects of their living with HIV. But not only are we able to gather the insights that are part of the program, but also now introducing interesting ways, including implementation science, to ensure that this has an impact on better care for this community. Clearly, our support for non-government organizations around the world is also important, but these continue to change. We often see, particularly under the circumstances of COVID-19, them being particularly challenged. So our continuous support of this group is really important, but also being able to identify new NGOs so that we can always ensure a very broad spectrum of support. And then finally, as an industry, we, I think, are in a unique position to be able to shape public health and policy. And it is really critical that we ensure that we address the multiple areas where either discriminatory laws or discriminatory policies inhibit access to care, because as an industry, this has been quite obvious, particularly in areas, in countries where, for instance, stigma is sponsored by the state. This is just an example of a meta-analysis that we have recently conducted on all the dolutegravir studies at ViiV Healthcare. And this data will be presented in more detail at the HIV Glasgow meeting in a couple of weeks' time. But just over 1,000 participants in various phase 3 studies in treatment-naive patients, looking at the health outcomes for different age strata of less than 50, 50 to 65, and over 65. You can see, as you would expect, the increase in the numbers of prevalence of comorbidities in cardiac, gastrointestinal, metabolic, nutrition, nervous system, and psychiatric diseases, as you would expect, increasing with age in both the dolutegravir and the various controls, and the various comparators. So the regulatory approach to the elderly is a relatively recent. They're often described as a special population, but of course the elderly are the main consumers of medicines. So they're not really a special population in the same way that pediatric population is. The ICH works closely with the various major regulatory agencies as shown here. And the main intention of their approach is to ensure that the study populations that are studied in development of drugs includes the spectrum of people that are intended for the use of that, and where those diseases are more likely to occur in elderly, to ensure that those programs are enriched with older participants. This, of course, has always been a struggle, even in disease areas where age is much more associated with those diseases such as cancer. This has been, as I said, somewhat of a slow progress. So this started off with a guidance that was issued by the FDA in 1989 for the development of the use of drugs in the elderly. And this was followed a few years later by the ICH E7, which was guidance for the industry of special populations, including the elderly. And then over the next few years, the agencies continue to develop their strategies, and the EMA published their geriatric medicine strategy in 2011. And this was followed by a publication the following year in the New England Journal of Medicine of this strategy, but also their evaluation of how this strategy was being applied. Over the next few years, further guidances and draft guidances were issued. Most recently, the FDA issued a guidance on how post-marketing studies, for instance, could address some of the shortcomings of development programs where people are lacking, older people are lacking in the participation of those studies. And most recently this year, the FDA issued draft guidance specifically focusing on enhanced inclusion of older people living with HIV in cancer studies. Of course, the intention of the regulatory agencies is to ensure that there are better information for both prescribers and consumers, and to ensure that there are age-appropriate inclusion of older people in studies where they're likely to be the recipients of those medicines. But this is a little different for HIV, where of course younger people are infected and then age with their infection, rather than being infected predominantly in an older population. And of course, finally, the enhanced need to reconsider some of the clinical endpoints that are much more age appropriate, such as frailty potentially, and this unique safety aspects that we are more concerned about in the geriatric population. These are some of the major areas where I feel we need to address to ensure that HIV does not hijack the process of aging for people living with HIV. HIV, as I mentioned earlier, manipulates multiple molecular pathways and cellular functions, and these often coincide with the aging-associated processes such as autophagy, and this profoundly impacts critical cellular regulation, cellular defense, stress response, and phenotype. This complexity provides some challenges, but I think it also provides several opportunities, and those opportunities, if addressed, may well benefit well beyond HIV. Persistent immune dysregulation and inflammation are hallmarks of HIV, both locally and systemically. But exactly how this intersects with age-associated inflammation and immune decline, I think also has implications for future care of people living with HIV. Minimizing inflammation seems attractive, but I also think we need a far better understanding of the drivers of inflammation and how to restore an overall immune function despite aging. Senolytics and senostatics are very promising and are being explored to address several age-related diseases. But of course, one of the drivers for senescence is the prevention of cancer. So as we start thinking about the introduction of these into people potentially living with HIV, we need, I think, to address some of the safety concerns, and also whether in a setting where we already have enhanced possibilities for cancer, that we don't unleash this in this population. Women with HIV differ from men in several ways. First of all, they have enhanced CD8 activation, interferon gene expression, and more inclined to have multiple comorbidities. And that is aside from the obvious neuroendocrinological, neuropsychiatric, and musculoskeletal complications and manifestations of menopause. So while I think there are several gaps in our understanding of how HIV is driving this, I think there are also major gaps in how women are managed as they age with HIV. And perhaps simply just ensuring a better implementation of recommendations for the multiple comorbidities that they face, and better treatment of the perimenopause time of their lives as they age would ensure better health outcomes for women. The transgender population is growing, and as they age, I think there are several gaps in our understanding of how to optimally manage this population. First of all, the hormonal treatments that they take and how these will interact with antiretroviral therapy and other comorbidities, and also whether this group would have a different pattern of comorbidities as they age. And I think there's much that we do not know about this population and ensuring their optimal care as they age. The multiple comorbidities, as I mentioned earlier, are particularly interesting in the setting of HIV for my mind, because of the way that these can cluster. And this invites speculation that potentially this clustering could offer an opportunity for a simple pathological pathway and a simpler intervention, and thus addressing many of these comorbidities at once. However, the exact drivers of HIV and how this intersects with the aging process and the accumulation of these comorbidities over time remains to be explored. Long-acting antiretroviral therapy and novel mechanisms of action offer huge opportunity for people living with HIV as they age, but there is much that we need to understand in terms of how these drugs are differently metabolized by aging skin and aging muscles, and also whether the long-acting drugs also come with long-acting adverse outcomes that need to be addressed differently in an aging population. We have known for several years that many of the comorbidities are benefited by changes in lifestyle and exercise. However, in a setting of aging and in the setting of HIV, we still have a lot to understand exactly what is driving the musculoskeletal manifestations of HIV and how exercise could benefit or not this population. PrEP is specifically targeted at a younger, more sexually active population, but of course the elderly are still sexually active too, and it is really important that we are able to engage in the older population who are at risk of HIV and ensure that they are both included in the clinical trials that we conduct for PrEP, but also that they are ultimately able to benefit from PrEP. And at the moment, I think this is somewhat lacking for this group. So our outreach to the older folk at risk is far less robust than it is for the younger folk. Vaccines, we know, are far less likely to respond effectively in an elderly population with an aging immune system. So the therapeutic and the preventative vaccines that we're developing for HIV need to take this different response to vaccines into account when addressing the needs of the older population. And then finally, a cure. So the promise of cure is extremely exciting and looking increasingly likely in the next several years. However, there are likely to be different responses to the cure strategies in an older population. And I think we need to ensure that in the absence of HIV, we don't have this offset in the older population by a myriad of comorbidities. And then finally, stigma. So the prolonged stress associated with stigma has substantial immunological, neuroendocrinological, and neurobehavioral consequences. The immune contributions to stress resilience and coping is likely perturbed in aging, as it is in HIV, and those who are subjected to long-term stigma. So is there an immune molecular signature of stigma and stress resilience in HIV? And how does HIV influence the co-regulation of the stress response by the hypothalamic pituitary axis, the autonomic nervous system, and immune response in aging people living with HIV? So in summary, the majority of HIV infections are in younger adults, and these are now fortunately aging, but they're aging with consequences. And often the same cellular processes that are impacted by HIV are those that are impacted by aging. The increasingly prevalent elderly population living with HIV are not a special population, but represent the most clinically challenging group, characterized by systemic inflammation, multiple comorbidities, polypharmacy, and the societal inflictions such as stigma. Our regulatory agencies have long recognized this complex nature of drug development intended for the elderly, but there are significant gaps in how we are able to ensure participation of the elderly in our clinical studies. And of course, the major challenges that are now emerging for people living with HIV are not only going to be able to be addressed by drug discovery and development. And as an industry, we need to ensure commitment to this population, recognizing their complex needs and addressing issues like stigma, and ultimately ensuring that when a remission or cure is secured, it is not offset by a myriad of age-associated diseases. So thank you for listening and giving me the opportunity to present some thoughts. I'll just leave you with some additional EMA and FDA resources. And you should be able to click on these and it will take you to these links. Thank you.